Bill and Cora Scott are the brains and the business acumen behind Brain Paint Neurofeedback. There are a lot of wonderful ways in which to receive neurofeedback in the world. Brain Paint happens to be the way that I utilize neurofeedback and deliver neurofeedback to my clients, and it's also the way that Sovereign Health delivers neurofeedback to clients. I don't receive any remuneration from Brain Paint. I'm not a salesperson for Brain Paint, so there's no payment involved. But my thanks to them is for putting together a PowerPoint presentation that helps those of us who are not neuroscientists or neuropsychologists be able to wrap our minds around what neurofeedback is, so that we don't have to get a PhD in neuropsychology to understand how this treatment modality can be helpful. So, thank you. Okay, but first we're going to talk about, we're going to take a step back and we're not going to talk about neurofeedback first. Really, the reason why we're here today is to talk about how to combine treatments. Not only neurofeedback, which is also called, by the way, EEG biofeedback, but dialectical behavior therapy, DBT. How many people have either a passing familiarity or more than that with DBT? So about half the people in the room. Okay, great. So again, I'm going to be very straightforward, and I like to speak in a way in which everyone can understand. I have a firm belief that if I'm speaking in a way that a 10 to 12-year-old can't understand, then I'm trying to hide something. I'm trying to hide that I don't know something. So, I really believe that. So the other thing I'd like to encourage everyone to do is to not hold your questions till the end. I'd prefer that you interrupt me nicely and ask the question, because I'd rather this be a dialogue and an interactive experience. Because if you have the question, you know how it goes, more than likely someone else does as well, and it'll just be more fun. An hour in the middle of the day can, oh, that got loud. Is the volume good? Yeah. Mm-hmm. I'm a very loud girl. I've never needed a lavalier for a discussion. I'm from New York. I don't, no one needs to hook me up, but for the presentation, they needed to hook me up, so Godspeed. I'd encourage you to turn off your phones, but if you forget, or if you thought you did and your phone doesn't get turned off, it's okay. The first time your phone goes off, we'll ask you to turn it off. The second time it goes off, you will do the hokey pokey. Okay? So let's talk about combining treatment modalities. Finally, our field has gotten, and I think truly our field in its entirety, chemical dependency over here, mental health over here. You know, we were on two different sides of a Chinese wall for decades, really. We finally gotten the wake-up call that we're one field, right? Have you ever met an alcoholic that didn't have anxiety or depression? Anyone ever met that person? I haven't. So finally, you look unsure. No. You're okay, you're holding out. 100%. Wayne is holding out. Anyway, I'm teasing. So finally, our field has come to grips with the fact that the dually diagnosed client is and are our clients. So we don't really, for the most part, put our chemically dependent clients over here and our dually diagnosed clients in a mental hospital anymore. That dichotomy is a farce. We accept the responsibility now that we need to do better, that we need to do much better, that we can't do, as we used to say, well, we'll treat the alcoholism now, we'll treat the dependency and the abuse now, and attend to the trauma later. Oh, really? I don't know about you, but if I have PTSD, if I'm having flashbacks and I'm sober, I'm not going to be sober for long. If I have OCD and the only way I can get through my day is by drinking, I'm not going to be sober for long. If I have compulsions that I can't manage without numbing myself out. We have to treat everything together. So how are we going to do that? We're going to do that by doing better. Now, on the front page of your handouts, It says creating transformation, not improvement. Now, that's very intentional on my part. I mean that. Who got into this field to help people make my least favorite phrase in our field, incremental improvements? Have you all seen that on a treatment plan? Johnny is making incremental improvements. I just want to shoot myself or somebody when I see that. Johnny didn't pay 20 grand to go to treatment to make incremental improvements. Johnny went to treatment to be transformed. That is our responsibility, is to transform people. I don't know about you, but I didn't spend $170,000 to go to college and graduate school to help people make incremental improvements. That is just bullshit, right? Okay, transformation. We're going for transformation, right? I'm going for transformation, and I believe that you are too. So we need to do that from the inside out and the outside in. DBT is skills. Dialectical behavior therapy is skills training. I like to tell clients it's everything we all should have learned in junior high school, and most of us didn't. It's also about creating a life worth living. That's the underlying philosophical underpinning, if you will, of DBT. When you begin to orient a client to DBT, you have to say, and whether it's your chemically dependent client, particularly your eating disordered client, but either one will do. When it's make or break time, are you going to puke up that chocolate cake today or not? Because let me tell you, puking up that chocolate cake is very seductive. It may not make sense to you if you don't have an eating disorder, but let me tell you, it's terribly seductive. You better have a higher purpose for a life worth living. And I'm not talking about your God concept when I say your higher purpose. You better have a notion for that better life that's on the way, that you're creating in your therapeutic skills training, for why you're not going to puke, for why you're not going to drink, for why you're not going to cut yourself, for why you're not going to do whatever it is you've been doing that landed you in that DBT session to begin with. Does that make sense? So there's these behaviors, and I call staying in bed because you have depression a mood-dependent behavior. So we get these clarified for clients as behaviors. People say, well, I can't get out of bed because I'm depressed. Well, I say, no, you made a choice to stay in bed. That's a whole new concept for clients. Oh, I made a choice to stay in bed. Wow, that's empowering. So we'll talk about DBT for a moment, but I'm so glad that those of you who were here last month got a good bit of DBT. It's very straightforward. It's skills-based training, and coupled with neurofeedback, you can be prepared to actually hear what goes on in the skills training because you will actually be regulated to absorb what's being taught. So, 4 modules in DBT. Number 1 module, who knows what it is? Just for fun. I know I'm the one supposed to be doing the instructing today, but does anyone know what numero uno module is in DBT? No one's going to take a chance? Okay, mindfulness. Now, how many people come into our treatment centers or even our outpatient private practices and can be mindful? Don't you love that? Someone's like one day out of detox and they get sent off to mindfulness group? Really? No. That's why they also need to be, by the way, going to their neurofeedback sessions. And that's why it's so critically important to me that these two things happen together. So mindfulness training, being in the present moment. Right now, I'm talking to you. I'm not thinking about the fact that, I'm trying not to think about the fact that my 6-year-old has strep throat. Okay, I'm with you. I really am with you. And the thought will come to me that my child has strep throat, and I will bring myself back. We're not robots. We're not perfect. We keep bringing ourselves back and bringing ourselves back. We all know this, right? We've all been beaten over the head about mindfulness for the last several years, the technology of mindfulness, in a number of different ways. So in dialectical behavior therapy, it has its own technology of mindfulness, as described and explicated by Dr. Marsha Linehan. Are any of you have a passing familiarity with Dr. Linehan's work? Okay, so a small group. So the mindfulness component is the foundation for the rest of the modules. The next component is emotional regulation. So how many of us need that when we get sober? All of us. That's what we've been trying to sort out, right? So the emotional regulation skills in dialectical behavior therapy are really beautiful skills, beautifully articulated. Again, I'm not going to go into a lot of detail because the neurofeedback portion really requires a great deal of work, and I'm not interested in rushing through this like a runaway train and then have you get nothing. I really want to do this in a thoughtful way where you feel like you walk out of here today with some meat on the bones. So the emotional regulation component has beautifully articulated skills where people go from feeling like their emotions control them, and it's an entirely new concept that they could actually have some control over going from 0 to 60 in a heartbeat. And then often being very slow to cool. Our addicts, our alcoholics, our depressed folks, our anxious folks also tend to be slow. Did everyone hear what I said? Slow to cool. So we can go to 0 to 60 quickly. We can call it holding on to resentments. We can call it whatever lingo is appropriate for your population, but we can be slow to cool. So we can stay revved for a long time. That's one part of our population. We can also have folks who benefit from emotional regulation who are numb. They never go from 0 to 60. So it's not just our people who are blasting off all the time or on occasion. It's also people who are just always or mostly vegetative who need to learn how to create more arousal in their life. It's people on both ends of the spectrum, and sometimes we forget about those folks because they don't cause us trouble, right? They're in the corner, and we forget about them because they're not causing us trouble. They're not causing their teachers trouble, and sometimes they're not causing their families trouble, but they do wind up in our treatment centers. And they're the person that doesn't tend to talk in group, and we have to remember to pull them in, right? And we can forget that they're there, and we have to remember to pull them in and pull them in and pull them in. And so the emotional regulation skills apply to them as well. Any questions about mindfulness or emotional regulation? The first two. Do I still have you folks with me? Okay. Okay. The third module in DBT is interpersonal effectiveness. This is my personal favorite because this is where people get their voice. This is where people who are aggressive, so no one hears them, learn how to turn down the volume so people start hearing them. And they start finding words instead of yelling, screaming, punching walls, etc. This is where our passive folks start to learn how to have a voice as well. So this is where we learn how to rest in the middle. This is where we do lots of role-playing and scripting, where we learn how to use our voice and say, you know, I have a different perspective, or I see it differently, or, you know, I know you want Italian, but I was thinking Chinese for dinner. You know, simple things that change lives. Many of our clients and us, by the way, I make no us and them distinction. I think our first prerogative as clinicians, marketing representatives is to share our common humanity and to be vigilant. At least this is how I work, and every successful person I know is vigilant to remember our common humanity, no us and them. As soon as you're all up in the us and them, your client's gone, and you can say goodbye to them. Even if they come back for a couple more sessions, they're going to be gone, right? Does everyone get what I mean? So the interpersonal effectiveness of, I have a different perspective, can I share it with you? Or, you know, I perceived something you said in this way, can I check it out with you to see if we're on the same page? Cora and I actually had an experience just a week ago. I perceived something in a certain way, and I called her up and checked in with her about it. We had a wonderful conversation. I love these guys, and so we're going to make sure we keep loving each other by communicating. But our clients don't have these skills. Most of them grew up in alcoholic homes. Or some kind of home, or some kind of silent, angry home, or even if there was no alcohol or drugs in the household, or someone had a thought disorder in the household, something, right? So interpersonal effectiveness, learning how to say no, with a period at the end of the sentence, with no justifications, explanations, or crawling up onto the cross as the martyr victim, right? You like that one. I can always tell when someone says, oh, she got me, right? So just saying, you know, no, that won't work for me today. Maybe another time, or not. You know, no, I can't help you with that. Period. That period at the end of the sentence is hard. Roxanne's barely breathing. Okay, so finally, another critical, I always like to say this module is my favorite, that module is my favorite. They're really all my favorite. Distress tolerance. We're in a job, and we need to get out of the job. Not that I would know anything about this. We're in a job, and we would like to leave the job. But you know what? It's really helpful not to make it any worse for ourselves or anyone else before we leave. We like to leave graciously, in our integrity. And so distress tolerance is not about sugarcoating shit. It's not about condoning things that are inappropriate. Excuse me to the live streaming audience, I do occasionally use a curse word. It's not about condoning things that are inappropriate, and I want to make that very clear because a lot of people, when they begin to learn about DBT and learn about the modules, there can be a confusion that distress tolerance means condoning inappropriate behavior or inappropriate situations. That is not what distress tolerance is about. It is about tolerating personal discomfort until one can get out of the situation. So, can anyone think of a situation where they have graciously tolerated something and then in integrity gotten themselves out of the situation in a way that was a win-win for everybody? Christmas dinner. That's a great, can you say more?
Just, you know, because I'm vegetarian now and
Uh-huh.
and they kind of look at me weird and just, I just go with it.
Right. So you don't start lambasting the disgusting carnivores who are immoral and blah, blah, blah. No judgment. No judgment. You've made a personal choice. And you tolerate. But that would not mean that you would allow anyone to be verbally abusive to you. That would not be appropriate, right? Okay. Okay, great. Okay. And for our folks who are recently sober, or who are highly anxious, this is difficult. I mean, it's easy to stand here and talk about these concepts in the abstract, but practicing this is extraordinarily difficult. So something that we say about dialectical behavior therapy is very simple, not easy. Simple, not easy. It is the first thing that I talk to clients about DBT, because you orient clients to the DBT modules. You don't just say, I think DBT would be great for you and this is the kind of therapy you're going to get. You don't do that. You get buy-in. This is a type of therapy that may benefit you. I'm going to orient you to it, and then you tell me if you'd like to participate. And again, the philosophic underpinning is creating a life worth living. I'm going to encourage you to do all this hard work and learn all these skills because you're going to get this. This is the payoff. This life worth living. It's not the life I'm going to create. We're going to do a vision board. You're going to do some artwork. You're going to do some journaling, whatever suits them. Because these skills are going to get you that. Not pleasing me, not pleasing your mom, not pleasing your dad, not pleasing your older siblings or your younger siblings or anybody else. Pleasing God, pleasing your pastor, pleasing your rabbi, none of that. That life that you want and nobody else. That's why to do all this hard work. And that's the first 2 to 3 sessions of DBT before you do a darn thing. It's different, right? We just have clients walk into our office and we start doing our thing with them once we kind of do whatever we do in our intake, right? So DBT is even started in a very different way. So that's my quick and dirty on DBT. Any questions before I jump into my favorite thing in the whole world? And no questions at all. Thank you. I got to have a question or else I'm going to feel like I failed.
Shari, why is the sky blue? No.
Well.
With DBT, I was introduced to that as a mode of treatment for borderline
Yes.
disorder.
Yes.
Which is, from what I understand, is why Marshall Linehan put the whole thing together.
Exactly.
To treat borderlands.
Exactly.
And in the book and in the workbook and everything, and the CDs that come with it, and so on and so forth. There's a lot of emphasis on the therapist needs. It's a whole team
Yes.
that does it, and that in dealing with the borderline personality, that you can't do this alone. You can't do DBT alone. That you need a buffer and a backstop and your own therapist.
Yep.
And so on and so forth. What I'm hearing from you, I didn't hear you mention borderline personality.
Right.
So are you, is what you're doing, are you excluding borderline personality from this particular mode of treatment?
Great question.
Just the recovering alcoholic or
Right.
and the an eating disorder person and so forth?
Right. Great question.
Are you a one-woman show over there? Is that the deal? Or?
I'm in private practice now.
Right.
And I am a one-woman show when I practice psychotherapy and neurofeedback. But I always build teams. I partner with psychiatrists, I partner with acupuncturists, I partner with massage therapists, all kinds of things, particularly because I treat a large population of people with chronic pain. So of course you have to have a pretty large village actually for folks with chronic pain. However, just to kind of answer your question in full, if you go to the DSM, not my favorite book by the way, but if you go to the DSM and look at the characteristics of someone with borderline personality disorder, you will notice that there's a dramatic overlay of your newly sober alcoholic. And what Dr. Linehan has done, to her credit, is a tremendous amount of research. Go figure. Someone who's built a treatment modality who's done research. She's done a ton of research with eating disordered clients and chemically dependent clients. And what she's noticed is that for folks with compulsive overeating and bulimia and chemical dependency, that DBT is a very effective modality. Anorexia, less so. So I don't find that I tend to use DBT to as much effect with individuals with anorexia. But the other, and I know anyone who's saying compulsive overeating isn't a real diagnosis, yeah, you're right. Anyone that has it knows that they have it, whether the DSM says it's a real diagnosis or not. So going by her research, although the BPD was the original diagnostic category it was used for, she's done a lot of wonderful evidence-based work to demonstrate that it's useful for those categories as well.
Does she still encourage the intimate team approach?
Not necessarily.
Not as much as with
Not necessarily,
okay.
Yeah, that's a really good question. Yeah. Primarily because that client population has a high incidence of parasuicidal behaviors. So you don't want to be getting calls every night, I'm going to kill myself, and be in that alone. That's the primary reason for that as well, by the way. Okay, yeah, exactly. Any other questions about anything, that or anything else? Yeah?
When you first take on somebody, do you tell them about any kind of a timeline upon which they might experience any kind of progress?
That's a great question. It depends on the client. I kind of going personally for me for the full catastrophe approach, but it really depends on the client. If someone has an eating disorder and chronic pain, but maybe 5 years of sobriety, it depends on how long they've had their eating disorder for. The folks that wind up in my office have often had their eating disorder since they were adolescents, and now maybe they're in their late 30s. They're going to be around for a while. But neurofeedback is going to alleviate them of many of their symptoms more quickly than they would expect. And I don't benchmark. I never ever benchmark because that sets up unrealistic expectations. but many of their symptoms will be ameliorated so we can get to behavior change. Neurofeedback is not a standalone treatment, but it will turn the volume down on some of the suffering so that we can get to behavior change. But no, you're always looking to lose the war if you start benchmarking. Yeah, that's been my experience anyway. So, any other questions? And could I get a time check? Oh, right in front of my face. It's 5 minutes to 1. Okay. So, EEG biofeedback, also called neurofeedback. Okay, so what is this neurofeedback? Who knows anything about neurofeedback? Okay, 3 people. Okay, so we are going to start at the very beginning. Okay, how many of you have children? Okay, some more. How many of you ever were a child? Okay. Okay. Still. This is an honest group. This is an honest group. Okay. Okay. Now, when you were 4 or 5 years old, depending on your kinesthetic aptitude, if one of your parents or caregivers had said to you, I want you to sit up very straight, not leaning too much to the left, not leaning too much to the right. Just sit up very straight, and now you will be able to ride a bike. How effective would that have been? Not so much, right? Don't be afraid. You can yell out.
Not effective at all.
Not effective at all. Okay. So we take these folks who are 11 seconds out of detox, and we sit them in a relapse prevention group. And we say, with our fabulous relapse prevention facilitator, we want you to make a list of your triggers. And you're going, we're even going to role play. If it's a really great treatment center, we're going to role play. And so is going to be your mother because she's your trigger. And we hope that this great experiential work is going to maybe make some changes in some part of the brain we're not really sure about. But maybe some experiential work is better than the stuff we used to do, maybe. Well, that's kind of like telling a kid, don't lean too much to the left or too much to the right. First of all, they're really still in detox, if not the early stages of post-acute withdrawal. So they are not hearing a damn thing you're saying. They're being polite. We have a lot of polite clients, even though we don't experience them as being polite. They're being a lot more polite than we realize. What really is happening when we learn how to ride a bike is that gravity is being processed kinesthetically by the brain. This is not an intellectual exercise. This is not a cognitive exercise. This is a brain exercise. And this is how we help people heal from the inside out. So, tools can assist the learning process. I am not suggesting that we throw relapse prevention group out the window. I love relapse prevention group. It's one of my favorite groups. Denial management is my first favorite group. Denial management and patterning strategies is my favorite group. But it's really my favorite group if someone has had 15 neurofeedback sessions, because then they actually hear what I'm saying. And don't you like it if someone's actually hearing what you're saying more than if they're not hearing what you're saying? Because it's kind of a waste of your breath. So how does neurofeedback actually do this as a tool? So neurofeedback via software gives the brain an opportunity to see itself in action. How many of you ladies would like to put your makeup on in the morning without a mirror? Very funny. I don't want to put my makeup on without a mirror. I need to clean up a little bit in the morning, and I want a mirror. I want a mirror. I get feedback from the mirror, right? You want a mirror? Well, you're gorgeous. You don't need a mirror. But the brain learns how to be increasingly effective and efficient. Now, how does it do this? There are 3 different protocols, and I promise this is as science-y as I'm going to get. I promise. Bill and Cora brought the most magnificent presentation, and I deleted 11 slides. I was like, nope, nope. People are going to get PTSD. Nope, that one goes, this one goes, that one goes. Okay, there are 3 protocols: beta, SMR, and alpha theta. And this is all you need to remember. Beta is like caffeine. okay? Just pretend that you get what I'm saying. Is like, oh, the microphone went away. Beta is like caffeine. Now the brain is forever complex, so I'm going to oversimplify in the extreme, okay? SMR is low wave beta. It actually stands for sensory motor rhythm. You don't have to remember that. That's not on the CEU quiz. But SMR is like a little bit of alcohol. Sounds good, huh? To some of us, it sounds good, I should say. Alpha theta is a protocol that's used for a number of things. One of those things is for our clients who have had traumatic experiences. It's used for many, many things. That's just one. So better focus and concentration, the ability to be more present, improving objectivity, mood stabilization, calm and relaxed. Now the most important thing to remember as I oversimplify this is that brain behavior and what we see as behavior in a person's actions are not intuitively matched. And what I mean by that is best exemplified by the behavior of an ADHD child. We give an ADHD child stimulants and what happens? They slow down, right? Well, that is what I'm talking about. We don't assume that an area of the brain that is over-aroused equates with over-aroused behavior. Do you see what I'm saying? It could equate with vegetative behavior if it's a certain part of the brain. I lost everybody in the room. Okay, so let's go back. I didn't lose you. Okay, you're the only one. So let me say that again. We all are aware that when we give a child or an adult, for that matter, who has this interesting diagnosis of attention deficit and hyperactivity, a stimulant that they slow down. Does everyone know that? Okay. What that exemplifies for us is that a part of the brain can be over-aroused, but that does not equate with over-aroused behavior. Because in the ADHD child, their brain is under-aroused, and that equates with over-aroused behavior. So it's not a 1-to-1, 1 + 1 = 2. Does that make sense now? I think I better explained it that time.
So it would be safe to say a person that has attention deficit would have a low beta wave or a low SMR?
Well, it's far more complicated than that. They actually typically have both. And they would have need for beta protocols and SMR protocols. What they don't have is the governor. Their governor is under-aroused. The part of the brain that says, whoa, don't throw your sneaker across the room at your teacher. Don't do that. The governor doesn't come online. The governor, the executive functioning, is not online. Did I say that right?
Absolutely.
Okay, he's the man right here. I'm very nervous, by the way. The man is here. Yeah, go ahead.
So a person with attention deficit, I always try to tie attention deficit to why somebody would want to use stimulants, as opposed to somebody who's really hyper, who has I call it a tired brain.
Okay.
And these things, I heard, I like that.
Okay.
A tired brain, we tend to have a person that has attention deficit has a tired brain. They're always trying to wake their brain up, so they like stimulants like that.
Exactly. Exactly. And that brings us full circle to the dual diagnosis issue. And I love to tell clients, let's honor your drug use. And they say, huh? And I say, you were trying to fix something. You're trying to fix something. And I'll give you an example. I had an athletic career. I never drank a drop of alcohol my entire life. My life. And guess what? I retired from my athletic career when I was 29. And guess what? 4 weeks later, I was hiding bottles of tequila. My athletic career, oh great, this is on live streaming, I forgot. My athletic career managed my anxiety disorder. When I was still very active. Oh God, it's nationally live streaming. When my athletics were no longer managing my panic disorder and my GAD, or whatever we'll call it 10 years from now, tequila did an exceptional job. Exceptional. So I like to say to clients, let's honor that. We're going to put some different tools in the toolbox. Tequila is not a helpful tool for if you want longevity in your lifespan. But let's honor that. because it's reality. And then we'll let go of it and put different tools in the toolbox, like maybe yoga or 12-step or yoga and 12-step and acupuncture or whatever resonates for that client. Remember the common humanity, it always goes far. So alpha theta, very important for our traumatized clients and for our clients with addiction, dramatically decreases vulnerability to relapse. Let's underline that, highlight that, chisel it on your forehead. Dramatically reduces vulnerability to relapse. Less self-absorbed, more open-minded, less defended. Wouldn't it be nice if you said to a client in your private practice or your treatment, you know, we're gonna do your timeline now. I don't have anything to put on my timeline. You know, isn't it a bummer when conversations start like that? More emotionally connected, increased peace and serenity, more objective observations. This is, you notice that objectivity is in both lists, but in the alpha theta column, this is particularly related to what we in this day and age call personality disorders. I hope we find a different term than personality disorders and characterological disorders someday. But if you line up 10 people and one of them has a characterological or personality disorder, they will have a very idiosyncratic perspective on a social thing, a social moment that occurs. They don't tend to have an objective perspective. And their idiosyncratic view of what occurs will typically be related to them. They will be the center of whatever their social take on that event was. And then accessing and integrating repressed experiences. And the very beautiful thing that neurofeedback does, particularly for our chemically dependent and eating disordered clients, is that it does this in a peaceful witness-observer way, unlike EMDR. Now, I'm a huge fan of EMDR. I have had 57 sessions myself, so needless to say, I'm a committed EMDR fan. However, I had 57 sessions of EMDR when I had 10 years of sobriety. It can be enormously overwhelming. And I don't know about you, but I don't want my clients, loved ones, family members, myself, having overwhelming emotional experiences when they're 3 weeks sober. And so, yes?
So you're saying that as opposed to EMDR, that alpha theta training can be used much sooner?
Yes, immediately.
I know that we...
Day one.
You know,
Day one.
If somebody's acting at all psychotic or at all... Day one. A lot of trauma, a lot of PTSD.
Day one.
We don't send them to
yeah, day one. I use all of these protocols with people on day one of sobriety who also have childhood sexual abuse. Because if you can turn the volume down on flashbacks, startle reaction, hypervigilance, you have dramatically increased their opportunity to stay sober. So you're doing hand in glove everything you're hoping to do. We cannot pretend that we can treat the trauma later. That is ancient history. So, again, neurofeedback is not a standalone treatment. So what I loved, what allowed me to really bring neurofeedback and brain pain in particular into promises in such a huge way. I don't know if any of you are familiar. And they still do, by the way, Promises have a very robust brain pain neurofeedback program, is that the increase in sobriety rates is outstanding. In fact, when Dr. Eugene Peniston did one of the first studies, if I'm articulating this properly, he was sort of laughed out of the field. The good news is that his studies have been replicated multiple times. And the results from the UCLA study, of which Bill Scott was the principal investigator, have been replicated by multiple other teams. And these are the protocols that are utilized by the brain pain system, which is why I'm the most comfortable with them. It's interesting when I talk about neurofeedback, I often say I'm a very traditional psychologist from New York. And I'm not waving crystals over anyone's head. Other people may be doing that, and that may work for some people, by the way, but I'm not doing that. This is evidence-based work that's been around for a very, very long time, and it dramatically improves both retention rates in treatment, by the way, dramatically, and so what I'm talking about is decreasing the AMA rate. Is everybody listening? Anyone trying to hold on to clients? And dramatically reduces the vulnerability to relapse, okay? So what are we looking at?
Shari?
Yes.
Just as effective in the underdeveloped prefrontal cortex, as like in the adolescent, as in the mature cortex?
Yes.
Prefrontal cortex?
Yes, in
It
fact,
doesn't make any difference.
yes, exactly, exactly. Okay, so what are we looking at? Just as the client with post-traumatic stress can get hijacked in a fight or flight loop, if I am an alcoholic and tequila is my primary food group, my only food group, and you take my tequila from me, that is just like taking food or water from a normal person, right? So this is what's happening. This is very cool. Check this out. Everybody paying attention? Now, what just happened? I got triggered. I saw something. Got to watch this again. Oh, it's doing it by itself. Now, what didn't happen? Nothing happened visually. I did not think through any consequences, such as my husband said he was going to divorce me if I drank again. I may lose my job if I go drink again. Probably shouldn't drive with my kids in the back seat. None of that. It was must get a drink now. So when alcoholics say, I don't know what happened, I just found myself in the bar, they're telling the truth, right? They're telling the truth. Now here's what happens after you've had a handful, and to this gentleman's question, which is a very important question, and we all want to know the answer, but there's just no firm, hard answer. This is what happens after you've had some alpha theta. Oh, I can start thinking through, I want a drink. I do want a drink, by the way, but I have a prenup that says I'm going to have to go to treatment. I really don't want to go to treatment again. I'm going to get my license taken away for good this time, et cetera, et cetera, et cetera. So you can have that second thought, okay? You can think through the consequences. You know, in the 12-step fellowships, we have that saying, you know, our minds can be our brain can be a dangerous neighborhood, except when you've had some neurofeedback. Yeah?
I was just confused. I thought they would have to go through the frontal lobe, the process, and then send a message back to the dead brain. And that had to go into the back of the brain?
That's where you have to visualize consequences.
And then it doesn't actually even get to be sent prefrontally because it's not even getting to the thalamus. It just starts to direct the sensory input directly back to the amygdala, and so they react before they can even the sensory information doesn't even get sent to the prefrontal cortex for decisions being made. And the second slide, when the cortex stops being bypassed, it goes priorly, and then it does actually get sent prefrontally.
Yeah.
Okay.
Yeah.
Biofeedback introduces pause.
Exactly. So, basically what I already said, but in my own idiosyncratic way, was that threats of ongoing recovery. Ongoing recovery is actually a threat. We can experience it as a threat. The brain experiences it as a threat. Neurofeedback trains us to avoid that experience as a threatening experience. And as a result, to better integrate the treatment process. How many people have been through treatment 17 times sincerely? And the days of us saying, well, maybe you need to do another 4th step. If someone said that to me, I might jump off a bridge. We have to do better. We must do better. Okay. I already mentioned this, that neurofeedback decreases the percentages of clients going AMA, there's something very special. During alpha theta protocols, if a client's brain waves increases to a certain hertz during 3 consecutive treatments, a warning pops up and says, this client may be getting ready to go AMA. I've done a lot of neurofeedback sessions, just one second, and so has my spouse. We do this work together. And that happened to him for the first time with a client in a sober living home situation, and he told the sober living owner, and the sober living owner told him he was crazy, and that this client was like their star client. And my spouse asked me, well, what do you think I should do? I said, call the family immediately. The sober living owner got very angry at my husband. 3 days later, the client drank. And the family was so grateful that we had warned them. And we sat down with the sober living owner and did a more robust explanation because he didn't understand. But we had called everyone and communicated what our concerns were. And he drank, and now he's in a different sober living. He's safe, and he's fine. But it's really cool, and it works. So you had a question. I'm sorry, Douglas.
AMA sounds like leaving treatment. What's that acronym?
Against medical advice. Yeah, I'm sorry. Okay, we have time, too. This is interesting. Okay, oh, my name is on here. After Dr. Corbitt implemented a brain pain treatment neurofeedback program at Promises, they realized a 46% increase in their clients' average length of stay. That's true. Who here is in marketing? Would you like to experience a 46% increase in your average length of stay? And that was at Promises Malibu. That was a very expensive increase in average length of stay. And a 60% reduction in clients leaving against medical advice. The folks at Promises and their parent company, Elements Behavioral Health, keep exceptional metrics. This wasn't me keeping some chicken scratch on a Post-it note. These were exceptional metrics that they kept, statistics. These are detailed. There was no rounding up. This is the power of neurofeedback complemented in an overall treatment program. Okay? And the results from the UCLA study looking at the comparison of relapse rates and long-term sobriety rates. I want to be the tall building, as my daughter would say. See what I'm talking about? You want to be the tall building? I want to be the tall building. Okay. Okay, I'm just going to keep going through a couple of these. You have all this information in your packet. There's a fabulous study written by Dr. Corbitt in Arizona together. Bill Scott's study, the UCLA study, which is really the seminal work in addiction treatment. And neurofeedbackdefined.com is the website for all things neurofeedback related. Neurofeedbackdefined.com. It's not on the sheet.
But the EEGbiofeedback.com goes there.
Oh, okay, I'm sorry. EEGbiofeedback.com. There you go. Thank you. Now, two things. There's one thing on this slide, but there's a frequently asked question that I get that I'd like to answer because someone's going to ask. The first thing is, are these gains permanent? You know, you take a medication every day and then you stop taking it, and unless it's an antibiotic, which is the only true anti-anything. Did you know that? Antibiotics are the only true cure of anything? You have to start taking it again, right? Or else you're kind of shit out of luck. The gains you make with neurofeedback are typically permanent. The only caveat to that is if a client has a traumatic brain injury or a severe seizure disorder, at some point in the future, if they're going through a significant life stressor, they may feel a need for a tune-up, but a tune-up is not 10 or 12 sessions. A tune-up is more likely to be 1 to 3 sessions.
So what's the average number of sessions
Good.
that you need in order for it to be permanent?
For it to be permanent, good question. It entirely depends on the person's condition. The magic number when it comes to addiction treatment and co-occurring disorders tends to be around 30 to 40 sessions, which we were able at Promises to bang out no problem in a person's treatment stay.
And we do it daily.
Exactly, exactly. And in other treatment programs, they would say, well, that's complicated, and how do you organize that? You know, you decide you're going to do it, and then you work backwards.
How long is each session?
30 minutes, 30 to 33 minutes. Yeah.
Can you just briefly tell me the difference between how the beta treatment and the alpha theta treatment?
Oh, great question. Great question. No, very simple. Beta and SMR protocols are eyes opened. And you're sitting in front of a laptop, you're watching very beautiful morphing fractal images. Alpha theta protocols are an eyes closed protocol. You're reclined at a 45-degree angle and you're listening to the acoustics. The eyes open protocol is you're watching the morphing fractals and you're listening to the acoustics. And you are truly, everyone hear this, painting with your brain. Truly painting with your brain. We're not putting anything into the brain. We're reading the EEG, and the EEG is being amplified through a little amplifier and painting these very beautiful morphing fractal images that are programmed by Bill. Very, very beautiful.
It's kind of putting people in a real meditative state in itself.
It is, but in answer to the question, because I was asked this on one occasion by someone who has a daily contemplative practice, they're very committed to their meditation, is this just meditation? And the answer is no. Meditation impacts the entire brain all at once. Neurofeedback is impacting specific strategic areas of the brain one at a time. So meditation is an all-over brain activity. Neurofeedback, you're doing, depending on where the sensors are placed, you're doing very strategic, specific work. Meditation is an all-over brain activity.
So I take it the expertise then with the person administrating it,
yes,
and where to put the...
Partly that. The other part of the expertise, one of the most important aspects, is there's a 90-question symptom-based evaluation, and the answers to that 90-question symptom-based evaluation customize and tailor the protocols. Your protocols will be radically different than my protocols. Not one person in this room would have the same protocols because all of our answers would be different. So there's nothing about this that is, there's no such thing as downloading an app. There's nothing automated. And the expertise, it is an automated protocol, but based on the real clinical acumen and the expertise of the person administering the symptom-based evaluation, which when it's done with real skill, it's a really beautiful process.
How long does it take to train somebody to do this? Because obviously you can't do all these.
Well, that's a good question. It depends on who the person is. So Bill trained me with, I don't want to say relative ease, but it didn't take forever, several days, a few days. Training my spouse, who's not a licensed healthcare provider, he works on my license, took longer because he doesn't know our lingo. We all share a common language, and we know what manic sleeplessness is. We just know what that means. We know what restless leg syndrome is. When you have to teach someone word by word what those terms mean so they can do an exquisite evaluation, it takes longer.
So generally it's preferable to have a clinician, to train a clinician to do the...
That's my preference.
To do the evaluation.
To do the evaluation.
Usually then technicians will run the session.
Yeah.
Oh, really?
Yeah. Yeah. I have 4 technicians. Oops, sorry, I touched the microphone. I have 4 technicians that work for my company, and they do beautiful work, but I supervise all of the evaluations.
What's the startup cost of this?
Normally,
Or is that relevant now?
it's very affordable. The Scots have really made it, that's how the Scots have revolutionized neurofeedback. Really in the world, it used to cost thousands and thousands and thousands of dollars, and then it made it prohibitive for a normal person to receive neurofeedback treatment. But a licensed healthcare provider or a chiropractor or someone who is in the healthcare field, $475 a month.
Oh, it's monthly. So
It's a monthly. You don't buy.
No month.
And there's no
you're not locked into
contracts.
contract.
Is that for the
It's 1
equipment?
month.
It's for the equipment and training.
So it really works.
It's on a month-to-month.
Can you do
Yeah.
it with any computer too, or?
Right,
We send the computer out.
Really?
Yeah, you don't have to buy anything. You don't
Yeah.
have to buy anything, you don't have to do anything. And it really works well in institutions because we have a lot of institutions, and what we find is not the practitioners, but the technicians tend to turn over a bit sometimes, and retraining them would be just very prohibitively expensive and time consuming because it would take a long time for the systems to be competent and confident.
Yeah.
So we train everyone, and it's included.
Yeah.
So we always have trainings going
Yeah.
on, and we just bring them in and
And
fix the full.
to that end, I can actually show you, all of you, I knew nothing about neurofeedback, and I'm scared to death of science. And we have 5 minutes left. Would you like to see how I got involved?
Excuse me, I have
Yes.
a question about
Sure.
The software.
Yes.
In most neurofeedback training softwares
Uh-huh.
involve some sort of video game that client
Right.
gets involved.
Right.
With brain pain, it just
With
client
brain-
sits in front of
Right.
the
Let me
screen.
repeat the question so that everyone hears. In many other neurofeedback systems, it involves either a video game or the client can even bring a movie that they can watch, but as their focus and attention wanes, the movie will slow down and stop. We don't use that type of a system with brain pain. As I mentioned, thank you for asking the question because many other people
I work with
may
brain
have
pain,
had that.
yeah.
Oh, you do work with brain pain. Wonderful. So
How do you keep your client motivated?
Interested?
Interested.
That's an interesting question. Again, I'm glad you asked it in case anyone else had the same question. It hasn't been an issue. My clients are early. They want to stay late. They re-up every 10 sessions. Most of my clients, I left Promises about 4 months ago, and most of my clients are going into their 30th or 40th session. And I'm very hands-off. I say, if you're feeling like you want more sessions, and they say, oh, shut up, and they're writing a check.
Oh, I like that.
They have chronic pain, they have eating disorders, and I combine it with dialectical behavior therapy when appropriate. And they're doing 12-step or they're doing whatever else they're doing.
We tend to find
Are
that
they
We had a
breaking
great
their
question
eyes
over
over?
here.
Yeah, yes, Robin.
Oh, we got the monthly cost, but what is it costing the patient to pay per session?
It depends on the
And if
setting.
they're not in a treatment
It
setting?
depends on the setting. It typically costs what psychotherapy would cost in that geographic area.
Which is approximately, let's say.
Well, it depends on,
It ranges.
Beverly
It
Hills.
ranges.
Around the country, it's
Yeah.
anywhere from $75 a session to MDs. Our MDs are $250, $350.
Okay.
so I want to show you guys a quick treat. If I could get some help. This is the Scots computer, and I'm going to plug in here. If I can, yes I can, because we have, and it's literally going to take 2 minutes to show you what I would like to show you. And I'm doing this to show you how easy it is to get involved if you're interested, if this feels like it resonates for you in terms of transformation. You up for it?
Yeah.
Sure.
Okay. Okay, so remember I said that I was a traditional psychotherapist from New York? Mm-hmm. Okay, well, once upon a time, long, long ago, in 1992, in a land far, far away, New York, there was a psychologist who practiced traditional psychotherapy. And then in 2002, she moved to California and got married and had a baby. 2 babies, actually. Oh, this is going to be on live streaming as well. I keep forgetting. Baby number 2, baby Emma, came along and changed everything. I promise this is relevant. Because you see, when Emma was 22 months old, she began having seizures, petit mal seizures. And the doctor recommended scary, debilitating medications. But Emma's mommy is a psychologist and started doing her homework about evidence-based, scientifically proven alternatives to the scary medications. Fortunately, Emma's mommy found the Scots and neurofeedback. And following 37 30-minute neurofeedback sessions, Emma never had another seizure, ever. And thus, Agora Neurofeedback, my company, I wasn't going to show this originally, was also born. And Emma's mommy, Dr. Mommy Corbitt, rarely practiced traditional psychotherapy ever again. And Dr. Mommy Corbitt, baby Emma, and Dr. Corbitt's patients lived happily ever after. The end. So that is it. It is one